Hello, welcome back once again to VIVA Unscripted here on the last day of VIVA 2017, our 15th year running this meeting. I think it's been a very productive week. I'd like to welcome to my left Dr. Robert Lookstein, who's interventional radiology and vice chair of radiology at Mount Sinai, and to my right, having braved the storms, coming from Baylor, Dr. Alan Lumsden. So welcome, guys. So, Alan, I want to start with you. First of all, you had a good week?
Yeah, great week.
Good. So you've obviously sort of been a pioneer and a leader in so many things, but I know that this week you talked quite a bit about aortic pathology, dissections. So tell me, where do we stand now sort of for the future of dissections? What's going to be the current role and evolution of branched and fenestrated devices, and how do they sort of fit into current practice?
So I think aortic dissections, are one of the more challenging disease processes, both to understand, to image, and then to figure out what to do. Let me back up from that and say that as surgeons, for many years, we've known that operating on an acute, for example, acute type B dissection is a very bad idea, okay? We cause more trouble than we prevent. Having said that, what's happened then is that when there are a group of patients which are pretty well defined, who have malperfusion. Now basically that means the dissection is cutting off the blood supply to a critical vessel. Patients who have pending rupture. Those are the patients who the presence of stent grafts has transformed. I don't think anybody would argue that stent grafts are the way to go. So that's a pretty well defined group. What's a much more challenging group is the patients who don't have those immediate indications to go ahead and intervene on them. And I think this is where you go back to some of the work that Mike Dake did, because that fascinated me. This idea that if you put a stent graft in, you potentially could heal the aorta and potentially cure the disease. Not in all patients, but I think what it showed you is where the stent graft was placed, you could resolve the dissection. So I think that's a very important biological message for us. Clearly we can't stent graft in the aorta from top to bottom, but at least it shows you where the presence of the stent graft is, that you could modify the natural history of that disease. So I can tell you that I've told all my partners, if I come in with a type B dissection, I want treated. I will take the upfront risks, because an article we wrote in response to one of the IRAD publications was once dissected, always dissected. When you get out to 2 or 3 months, I think the game's over in terms of stent grafts at that point in time. About 30-40% of these patients will undergo progressive dilation of the aorta, and those are really difficult situations to deal with. And you commit these patients to lifelong antihypertensive therapy, which is not without its problems. And probably the reason they keep getting bigger is because it fails, and we don't do a very good job at managing blood pressure.
So would you suggest then that maybe the current paradigm of medical management of uncomplicated type B dissection should be revisited because we can mitigate this natural history?
I do think it's worthwhile revisiting. It needs to be done in the setting of a clinical trial. Now, clearly there are risks associated with it. And when you put a stent graft in, you look at upfront risks. And the upfront risks are paralysis, retrograde dissection are probably two big things that we worry about. And so that really does need to be evaluated.
I'm going to come back to that point
Sure.
in a minute. So kind of working from really large vessels down to really small vessels, although we could stop somewhere in between. I've known Dr. Lookstein for many years, and he's really shown tremendous leadership in treating complex tibial disease, and in particular, coronary drug-eluting stents, has published some seminal work on this. So, my impression has been, as we do more difficult critical limb ischemia, that in some respects, our skill set is exceeding our tool set. And this is particularly true with regard to tibial stents. So, talk about how you utilize tibial stents, what we're missing, and if you could sort of, have a blank check to design these products, what would they look like?
So, these are all really good points. Right now, unfortunately, in the United States, as you know, we have no dedicated implant whatsoever for the below-knee circulation. We don't have any labeled anti-proliferative delivery system that has shown efficacy in a prospective trial for the below-knee circulation at all. And so we're really left with plain balloon angioplasty and, in certain circumstances, atherectomy. These technologies are clearly limited. They're associated with acute failure, high rates of target lesion revascularization, and unfortunately elevated costs and morbidity for patients with critical limb ischemia. I think there's a great opportunity to obviously generate prospective data. We're hoping that the Lutonix BTK trial does finish enrollment soon. and answer some questions about what the role could be for drug-coated balloons in the baloney circulation. My own personal opinion is I think there is a need for a dedicated implant in the baloney space, whether it's going to be a balloon expandable implant, a self-expanding implant, what are the pharmacokinetics that are necessary for this particular population where you have high preponderance of diabetes, renal insufficiency, renal failure. We don't know yet. Obviously, the space is wide open. If I had a blank check, I would say that we would want to look at a prospective randomized trial comparing drug-eluting stents for the baloney circulation for long lesions. Somewhere between 8 to 15 centimeters in length, and unfortunately right now in the U.S. compared to balloon angioplasty, and obviously shows 6-month and 12-month patency, freedom from major amputation, and then freedom from reintervention.
So I take it from what you're saying that you think that drug delivery in addition to stents is going to be necessary. I mean, there are companies now making specific tibial, nitinol stents, very tightly packed stents as part of the limb flow. There's a stent graft system.
Right.
So what do you think of those technologies? And related to this, do you think that the bioabsorbable stent enterprise is now dead, or will this be revisited?
So I don't think there's any data, to my knowledge so far, that has demonstrated that at least short stents fare better than just plain old balloon angioplasty. Bare metal stents fare better than balloon angioplasty, either in a balloon expandable or self-expanding paradigm. So I really do think that drug delivery is the way to go in the future. We've obviously had a handful of prospective randomized trials in Europe that have demonstrated success in short lesions. The unmet need is really for long lesions. And as we're tackling more complex cases, as you mentioned, we're really dealing with the issues of acute failure and then how to avoid reintervention in the midterm and eventually the long term here. I believe that a drug delivery platform is going to be necessary to achieve long-term patency. I was very enthusiastic about Ramon Varco's data with the bioabsorbable scaffolds in the below the knee. Obviously now we're in a uncertain regulatory climate with that device being withdrawn from the global marketplace. I think there's a potential role for bioabsorbable scaffolds in the below the knee, but I think in the immediate term we're probably going to be looking at a more traditional drug-eluting permanent implant for the critical limb ischemia patient population.
Great. So let me go back over here, Alan, and talk a little more about aortic and some other things I want to talk to you about in the time that we have. But just you talked about extending these dissections, which obviously brings up the issue of arch and treating arch pathology. I know you didn't talk about that this week at VIVA, but have clearly insights into that. Is it going to be that type A dissections are also going to be endovascular? Where do we stand with these technologies?
Well, there's an ongoing clinical trial at the moment, actually, which we're part of, is in treating type A dissections. Mm-hmm. This is a trial sponsored by Gore. It's in its early phase. I think that as we go more and more over the arch and into the ascending, I think that the world we're going to live in for the next 5 years is about stroke and how do we mitigate stroke. And that's something that we're very interested in. And so, yeah, there's an ascending trial which is running at the moment. I can't really tell you anything about the early data. There's only a handful of patients that have been treated. Arch is a whole different ballgame. I mean, I think technically that is certainly feasible. The branch grafts which are available at the moment, you can do them, but the limitations again in all of these trials is stroke, and how do we prevent that?
So I know that there's tremendous interest with TVAR with embolic protection devices. Is there any similar sort of device or strategy that can be used during dissection repair?
Okay, so let's talk about when strokes happen. First of all, you have no idea, and that's what I would submit to you, is that we're interested in, from TAVR to TVAR to branches, because I fundamentally believe in the use of transcranial Doppler monitoring.
Right.
And all of these things, the target organ is the middle cerebral aorta. You must know what is going on in the MCA real time when you're doing these procedures. You can't basically waken the patient up and go, hey, they got a stroke, fix what? These are highly complex procedures with multiple manipulations. You can't figure out what you need to fix. You need a signal which will allow you to have some idea of when these embolic events actually happened. And many of our colleagues here for years will go, don't bother me with the TCD. It shows me way too much information. Probably not, okay? There's no such thing as good emboli that I'm aware of going on up into the head.
Right.
It may bother you to hear that it's actually happening, but I think the new stroke classification system that came out or from NeuroWark says, we got a problem. These are subclinical. They don't have clinical manifestation. This is dead brain, and we got to figure out. And so I think there's going to be a whole wave of interest in embolic protection devices. But at the end of the day, I think you got to be able to monitor this real time during the procedure, and I need to be able to say to you, Bob, nothing happened during that phase of the procedure. You need to focus on the stent deployment or the catheterization, for example. That's the information that we're going to need.
Right, and something, these sort of silent events are really relevant. I'm sure you saw the debate yesterday talking about transfemoral versus transcervical carotid intervention, and Dr. Schneider pointed out you see a lot of hits on MRI, and they're not all clinically relevant, but clearly they're not good for you. Right.
I'm actually curious, Alan, how do you think that type A dissections associated with malperfusion should be managed in the modern era, especially as we're emerging into a completely endovascular approach to type A dissection? I'm just curious what your insights into that are.
Again, this is a conversation that needs to happen institution by institution with heart surgeons, is that they're kind of under the gun in doing this, and there's a mortality rate associated with doing it, and they've never really been willing to do an extra component. Now that extra component could be as simple as putting a side branch on and revascularizing the innominate artery, and then giving you a landing zone in that ascending graft. So you got to move the innominate takeoff branch as close to the valve as you can possibly get it, because then every option is on the table. So that's option number one. Option number two is to do a hemi-arch, reimplant an island, and potentially put in a frozen elephant trunk. I think that there are so many of these patients who come back, if not with acute malperfusion, with progressive dilation of the distal dissection, and it's very difficult to know how to treat them. So just given the option of doing one bypass intraoperatively, and they can really do that when they're rewarming the patient. This is typically done with the patient in the hypothermic circulatory arrest. You got a period of time where there's nothing really to do, and putting a side branch on, I think, would be very helpful.
Interesting. Rob, on the way over here, we were talking about PE. Obviously, that's been a focus of the VIVA daily publication. So what's your perspective on PE? I think I told you that based upon early NIH trials, we saw a lot of hemodynamic improvement, right heart dynamics, but no changes in morbidity and mortality. Do you think we need trials that are going to look at these hard endpoints, or do you think the evidence is clear with what we're doing?
I don't think the evidence is clear at all. I think this is an incredible opportunity to generate a lot of data. There's opportunities for acute symptomatic rescue in a massive pulmonary embolism cohort, and I think you're going to see an evolution of thrombectomy and thromboaspiration systems evolve to meet that unmet need. It appears that as we talk about these issues around the country, that there is a disparity of access to a open surgical embolectomy as a primary treatment for an acute massive pulmonary embolism. So I really believe that industry partnering with committed physicians will meet that need. And obviously, there's going to need to be trials to demonstrate safety and feasibility for a endovascular approach to acute massive PE. There's about a handful of entrants into the market right now, of various levels of complexity. I've tried them all. I don't think that any of them are a grand slam home run yet. They clearly need to be iterated to really be widely adopted and available across the country. But it's a good first step in the right direction. The other issue is how to deal with submassive PE, and I think Aki Sista has been very transparent this week about discussing his ongoing submission to NHLBI about doing a prospective randomized study looking at minimally invasive therapies for submassive. It's a very, very controversial topic about what the endpoints are going to be. The mortality signal is clearly not going to be able to be met in a prospective randomized trial, and so can you develop a surrogate based on functionality, quality of life to be able to demonstrate or advocate for a endovascular approach for this cohort?
Yeah, we don't want to come up with another medical reversal here, right?
Right, exactly.
Can I ask Bob one question?
Yeah.
Sure.
I mean, you're talking about long-term outcome events. I still don't know what the short-term outcome events are. When you're in there and you're trying to take clot out, where do you stop? I mean, you never get it all out, and the question is always...
That's an excellent point. And I think, 10 years ago, I think all of us that were doing endovascular therapy for either submassive or massive PE were going for that perfect result. And I think that there's been a global shift away from that now, largely predicated by a observation of adverse events, going for a more aggressive approach with this specific disease. I think now most operators are looking for an acute reduction in right heart pressure on the table, even a modest amount, 10% reduction, 15% reduction as an endpoint. And the question is whether or not there's going to be an ongoing role past that acute reduction in the strain on the right ventricle for either catheter-directed thrombolytics or systemic thrombolytics, just to get the patient through the next 72 hours.
We know it improves after they get off the table as well, and LV improve. I normally like to end with a minute of sort of social engagement, but I'm not going to do that because you and I have a common interest, which is sort of fallen by the wayside, which is robotics. And just tell me, I mean, where are we? The company that was making the predominant tool for peripheral vascular robotic procedures is currently sidelined. You think we're going to sort of revitalize this?
So I don't know the answer to that. It's in terms of Hansen. I mean, they've focused now. They're bought by Auris, and their focus is on endobronchial navigation. My hope is that a lot of the things they learned from that can be brought back into the vascular space. Now, we just bought Corindus, and so we're actually planning to kind of re-engage. It's not, the interesting thing was the original Magellan platform navigated but didn't deliver therapy.
Right.
Corindus doesn't navigate to target. You got to put it in the target, then it can deliver therapy. Interestingly, the Corindus will fit through the Hansen robot. So you can potentially combine two robots. So one of the things that I'm really interested, there's been a lot of discussion about how do you deliver stroke care at this meeting. And it's fascinating because the trials have all defined mechanical thrombectomy and said, this is the gold standard. Oh, by the way, if you don't live in a big city with acute stroke, you're just screwed. You can't get therapy. And so I'm really interested if there are alternate techniques where the guys from the stroke center can actually either sit on the shoulder of the best hands that's available using remote communication, or whether you can actually a lot of people can put a sheath up in a carotid artery. Can you then give them control? Sure. Because Corindus is looking to do remote coronary interventions within the next couple of years.
Right. Having been out to their facility before they shut it down, I know you have as well. I think we're going to see a day where this is fully automated. We become like radiation oncologists. We program the intervention and the machines do it. It sounds a little bit like Skynet, I know, but it's certainly feasible. I think that's our time. I didn't have a chance to talk about Tuscany and other summer vacations, but maybe next time. I can't thank you guys enough for being a part of both VIVA and VIVA Unscripted, and wish you safe travels and a very successful year.
Good job.
Thanks, John.
Thank you.
Thank you.